from neuro speed, for Eno and also for Aneurysm. It's very rigid, it's not, but normally we try to not cross again. After that you use neurospeed cross again, maybe it should be a problem. You should have get considered then you have the stenosis because neurospeed is not very easy to navigate.
So now we go to the next case. Thank you.
Thank you.
Dubai, hello. Hello, I hope you can hear me. Nader? Can you hear me?
I can hear you, but I cannot see you.
We can hear you. Видео можно будет подключить? Видно? Just a second. Нас видно? And now? Video is available?
We cannot see you. Wait a little bit.
Okay, okay.
Yes, now we have to shift. We have to shift. Yes, now we can see you. Good afternoon.
Hello, good afternoon. Nice to hear you from Dubai, and I heard a lot of colleagues and friends just arrived from IQ Stroke in Istanbul. The colleagues from South Africa and Bangladesh, Mufas and I think Hassan was in Istanbul airport with my colleagues. And we are happy to present live case. This is a case number 1, I hope. Young lady, 76 years old, just after myocardial infarction in December, and on CT angiography, ICA and MCA aneurysms and right carotid artery critical stenosis was found, and also there is aneurysm on the left side on ICA. Now I will present the PowerPoint presentation. Just a second. I hope you can. Just a second. We will share the screen. Just a second. Just a second. Okay. Before the presentation, we have images ready. I hope you can see my big screen. Nader? Экран можно будет подать, Жень?
Yes, now you can see.
Now you can see, okay. This is a 3D from right common carotid. And this is aneurysm nearly 12 millimeter with the preaneurysmal stenosis, and this stenosis size is nearly 1.6 millimeter, and the ICA proximal is 2.5, and distal is nearly 4 millimeter. Maybe it's a dissecting aneurysm, maybe. The aneurysm size is 12 millimeter. Because of this stenosis, we are planning to do for this aneurysm balloon assist coiling first. And also there is a MCA aneurysm on the bifurcation. We'll do stent and balloon assist coiling for this aneurysm. And let me show you. And patient under local anesthesia. Our anesthesiology team said, okay, it was a fresh infarction on myocardium, and please do under local anesthesia. This is critical stenosis of the carotid ICA. Now our guiding in the common carotid. We gave heparin, 5,000 international unit, and patient premedicated with ticagrelor. Мы тест не делали, да? Yes, we finished all cartridges for aggregometry, and it's just a ticagrelor with aspirin on board. Heparin already given, and now I will show you the PowerPoint presentation. Just a second. Yes, that? Okay.
What will
Okay, the presentation is not ready. We can continue. If you allow me, we will continue with the case. The PowerPoint is not ready. If you have any questions, we can hear you. No problem. The guiding is 8 French, which is Neuromax 6 French. We navigated through the 6 French coronary Judkins right guiding, and we have short sheaths from Terumo and Neuromax with the 2 Y connectors. Just a second. Okay, AP and lateral. Ekrán center Jason. Yes, I can hear you. Okay.
We have a question about MCA that seems
Could you repeat the question, because it's a little bit noisy in the operating room? It's small, yeah? Можно будет аудио включить? Just a second. We switched off the audio in the operating room. Можно будет включить? We have no voice in the operating room. Just a second. Okay. Now fixing the problem with audio. We prepared 7mm Pronder protection system from Lepo Medical, and we're navigating Pronder through this 14-wire Xeon Blue. Now we'll place the Pronder. Okay, it's time to time such a problem. Huh? Okay. Now protection device is in place. Could you speak something? I need to check the voice. Now I can hear you. Yes, now I can.
So this is Paul.
Yes, Paul.
The question was, the MCA aneurysm distally is very small. Do you treat those aneurysms regularly, or is it because of perhaps more difficult access after you treated the ICA aneurysm?
Usually, yes, we treat them. Usually, yes. Не власas.
I got another question. You're looking very good. Now we have
Smart mask I think the 3mm MCA aneurysm should be no problem, but only problem could be local anesthesia. It's a 5mm balloon, Sterling. Now I'm asking Maksat to give 6 atmospheres. Okay. It could be TIA, yeah? Okay, we'll repeat the angioplasty. Еще раз. Yes, patient is planned for coronary bypass. That's why it's better to treat both aneurysms. Sometimes cardiac surgeons scary because of the aneurysm intracranial. We did angioplasty with 5 mm balloon, and now exact stent from Abbott, 9740.
So, another question, why did you make a PTA first before stenting on the carotid?
Cheers.
Some people say that it's more risky for emboli.
Yes, Paul. It's our regular practice. We prefer to stent first, to angioplasty first, the risk of emboli, then less. Because of the laser cut stents we were using, I think it's actual. And I know in your practice, and it's a practice of Professor Chapeau, the main stent is carotid wall stent. That's why maybe post-dilatation in some point is better, but this is critical stenosis. It's less than 2 mm remaining diameter. And now you can see how easy exactly is opening. It's just rotation of this part. Okay, we decreased the blood pressure, now is 100, and the slight bradycardia 51, and I think it's not problem. I preferred to not to do post-dilatation, just will take up my neuromax. And now I will take out the stent. Okay.
I have a question.
Okay.
You don't have to use what was standing for a moment, you use a lot of to stop the reverse the flow.
Unfortunately, the balloon guiding like cello or from the Mercy balloon is not available in Kazakhstan, and nowadays Armadillo is just arriving, but I tried one and it's quite stiff and I couldn't inflate the balloon. Maybe my preparation was incorrect a little bit. Just a second, I will check the flow. That's why in our practice the MoMA system was out from the market since 2015, I think, and then we start to use only Spider. And yes. Hi, Tariq. Yeah.
So you put, as you were saying, the patient is scheduled for a CAD.
Yes.
So, tracing has been put, tracing via, or you just manage it in atropine?
Atropine, just atropine. Now the pulse is 69 and atropine is working. Just a second. And this is, I think this is working projection. 2 and caudal 2. Okay. Yes, the experience with the carotid stenting in our country is filters. And for the stroke cases also, we're using just 8 French guiding catheters. And nowadays we combine aspiration with the stent retriever. There is no balloon guides available in our country. Okay. That's the view. We prepared for the aneurysm eclipse double lumen with the Chikai 14 black, and for the MCA it will be the same setting, and I think there is a slight spasm. We can pull a little bit the holding catheter. Smart mask. Okay, it's very important to see the spasm because the navigation of balloon and the microcatheter may cause the dissection in such a tortuosity. Yes, I will repeat the answer, but maybe it will work. Yes, it works. Just a second. Yes, now it's okay. Yes, there is some stenosis in cavernous also. And as you noticed, in Kazakhstan we have multiple stenosis patient, and it's quite different from the European countries, and maybe it's different from Arabic countries also. Yes, there is a bifurcation aneurysm on the ICA also. There is a small bifurcation aneurysm there. Okay. Yes, and all the time dilemma, which aneurysm first? MCA or ICA? Paul, Tariq, what is your recommendation? Which aneurysm first? Okay, let's see. Maybe we will start with the MC, then we will fall down to ICA. Let's see. Yes, the second device is easier. Yeah, second is good. Yes, the navigation is not so complex. Maybe we will start from MCA first. Yes. Yes. Yes, now we're in the upper branch, and I think first of all we need to place little baby, and then we can place the coils through the same headway. Just a second, we moved all anatomy. It's also possible to do balloon assist coiling for the upper branch and diameter massage. Yes, and we have this problem with the Phillips. Just a second. Бақыт спираль бер. Now I will take coils. Şey altı birisi.
So you can
Based on my last review, doing
Yıka.
average has very questionable evidence behind it. So a lot of some centers characterize the quad, some centers characterize the quad, so it's mixed.
Yıktı altı. Bak, Leo baby var. Leo baby. Yıkacağım.
If you add to that fixing the aneurysm, add to that
Yıkacağım.
add to that doing it local, not anesthesia, that makes the decision to go head and neck first. Or asymptomatic is right, or pre-catheter.
surgeon also the cardiac surgeon, surgeons who can manage with the local variation and they can avoid the environment which is happening. It depends upon the surgeon also.
Technically, I'm not going to generalize, but I'm just telling you my regulations. That if it's asymptomatic, I'll probably prioritize catheter.
Yes, we took a little baby, Nader. Now we have little baby inside the head weight 17, and Eclipse is located in lower branch and head weight 17 in the upper branch, which is most involved in the aneurysm neck.
You're using a single level, right?
It's a single balloon, double lumen balloon, but single. It's a so-called balloon and stent assist coiling. We had a publication with the Paul, René, Kublai, and Pascal Mossiman also was in this paper. Yes.
So for the juniors in the room, the shield that the doctor is using is a zero gravity shield. And I think for people who are going to practice this long term, it's very important to take care of your joints and back. You need to keep an eye on your posture, your weight, and general fitness. So that's one way of reducing the weight and wear and tear on your body. I don't. Just keep an eye on your posture, your weight. I think overall general health is very good. And I think one of the things that people say that these procedures are not race, I think the more that you stand is not good. So being actually assiduous in procedures really matters on your joints. And there are other things you can do with the apron, having a belt on the suspenders also are important. So there's a lot of things you can do. There's chapters written on this. But this is just one thing that you can do if you have anybody else that might help. I find it inconvenient. He's using it very efficiently.
Yes, it's a very good comment, and with the zero gravity, with this system, I can go out and gravity is sterile, and at any time of the procedure I can go again inside, and I'm not swearing, I'm completely dry, but my assistant Maksat is completely wet at this moment of the operation. And unfortunately this...
Some of us are sweating outside here.
yes,
Very hard pace.
it's hot in Dubai. But Nader organized the meeting at the nice time. My family visited Dubai just 2 weeks ago, and they said it's quite cold outside. And now I think it's a little bit warm. I hope you can enjoy Dubai.
You will experience this tomorrow.
Yes, I hope so. Now I will re-navigate my... Yes, unfortunately the system is little bit kaput. That's why roadmap is all the time moving. Huh? Just a second. Sometimes it's a little bit complex to navigate inside the aneurysm. Just a second, I need to turn my light. It's a low baby, I think. For the LVCO, it's very important to have a Teruma GT and to do the G1 maneuver.
Yeah, so probably that really can happen with the GP here also. That it will do re-negotiating that because the GP has got a much more organ force which is very advanced.
At the moment, number one, we have a jailed eclipse. Maybe we should re-navigate the eclipse, and it could be point number one. We narrowed the space. Maybe now I can re-navigate my balloon inside the stand. Yes, it's not all the time easy. Just a second. Yes, now it's easy. Just a second. Yes, now we are in the lower branch. Then it's quite easier to re-navigate. Okay. Yes, it's pushing the stand. I hope in the future the tip of the eclipse will be more like knife. Huh?
Okay. Yes, one remark I made is it's interesting how treating acute strokes changed a lot of long-held beliefs in neurotransmission. When I was training, we would have any movement. But I think our experience with acute stroke, seeing these moving patients, gave us a little bit more comfort navigating blindness, blinding and tolerating a little bit of movement. I think that's part slower from acute stroke treatment.
Yes, but I think the problem is not the patient movement, the problem with the system. Yes, patient is moving, but the system is moving also. Okay. My headway is just on the wall of the neck of the aneurysm. Maybe we can place.
You can prefer usually to point and first and then to pass fluid to each aneurysm, or you use the microcatheter sometimes, especially when it's a small aneurysm.
It's a little bit cold in the operating room. That's why the patient is complaining. Okay. It's cold in the operating room. Just a second. I will check the position of the coil. Yes, we a little bit changed with our stand and with balloon the anatomy, and now you can see the coil is exactly inside the aneurysm. Yes. Okay. Just a second. Қозғалмаңыз, не шевелимся, не шевелимся, не шевелимся. Скоро заканчиваем, буквально 10 минут, и мы закончим. Не алып сөзір. Sütürsün. Bir jarımda 4 деген spiral бересің. Бересің. Okay. I'm so sorry that it's not in the general anesthesia and everything is moving, but
We found very clear from you what kind of distance.
it's okay. For us it's okay, we used to work in this condition. Okay, balloon is not going inside the... Қозғалмаңыз. Не шевелимся.
So if you have a cardiac patient who needs a wait for a home procedure, that might actually stress the heart.
Yes.
So we're trying not to intubate to leave the heart, but the patient for a stressful procedure without intubation might actually be stressful. So there's a balance there. So you're avoiding anesthesia, but an awake patient might have anxiety and...
Не шевелитесь, пожалуйста. Не шевелимся.
The patient is not sweating, is feeling cold, is not under stress.
I think Maksat and me in a bigger stress than patient. Шевелимся. Қозғалмаңыз. Yes, it's clear. I hope it's okay. 2 coils and stand.
Не шевелимся. Не шевелимся.
Дайте, пожалуйста, чуть-чуть седацию, а? Можно будет чуть-чуть седацию? Okay, now the second coil is inside the aneurysm. Okay, no problem. The aneurysm is coiled.
Не шевелитесь. Все нормально? А?
Okay. Все, стоп. Так, без лишних движений, пожалуйста. Без лишних движений. Okay, now we take out our headway and now we are inside the MCA aneurysm. Okay, just a second. We'll take out our balloon, and balloon now at the level of MCA aneurysm.
Не шевелитесь.
Yes, in essence there is no problem with Jürgen. I think the Professor Chateau is more lucky, and in our place we should work in this condition, but it's okay. Okay. Just a second. Yes. Yes, now we can see the aneurysm and stop. Okay. MCA is okay. Now we will start to coil the ICA. Just a second. Okay, the balloon is in place. First coil will be Toes microplex Sarsen. The first coil will be 9 millimeter. Okay, just a second. Let's measure.
Не шевелитесь, не шевелитесь. Скоро заканчивать.
12 by 7. Okay. I think the balloon is just for the security, and the neck of the aneurysm is quite okay. Because of this proximal stenosis, I think we will see at the end, do we need credo stent for the ICA or not? Okay. I will take back a little bit my headway. Келесі спиральдар ұстауыз, 8 ба 7. Жеті бере бір, бақыт. 22. 23 aşağıda. The first coil was 9 millimeter and second coil was 8. This is 8 millimeter. And the coil number 3 is 723 microplex.
Не шевелитесь.
Что происходит, а? Что происходит?
Не шевелитесь.
Just a second, it was a little bit confused because of this. Well, спросите, она себя хорошо чувствует? Спросите, пожалуйста, она себя хорошо чувствует? Now it's a sedation, yes, it's look like this. Саша, это же не седация, у нее. Yes, it's not sedation, but it's sedation. Okay. Is it sedation in your place? Looks like this, the same? Okay. Yes. Okay. 7 миллиметров таяшылır. Another, we have one more case. If it's okay, we can prepare him. Nader? Okay. Yes.
Just for the juniors, sometimes you might deviate from general anesthesia for selected cases, and one of the, it's very rare. Well, not, it's not practice. One of them is actually when you want to do selective
миллиметра.
You need to keep them awake. So some spinal cases keep them awake. Some AVMs like this done before. But those are extremely rare cases. If I'm dealing extracranially and middle meningeal, I might do with sedation. It's generally speaking, intracranial, if you have a wound that's bigger than the vessel, how often do you go with the you're limiting the chances. I think this is a lot of exceptional state to do. But I just wanted to comment, sedation sometimes might be the way to go if you want to do some testing, if you want to do some water tests, on spine cases, AVMs.
Yes, it's not detaching.
Runs are doing a whole way. I'm including this one.
It's not detached. Берер. Алтын бересің. 4 берер. 4 тон. 4 тон сарысы. Я берер. Yes, Paul, there is a problem not from our side, problem from the anesthesiology team, and they're scared to give a general anesthesia. We need to appreciate the decision of anesthesiologists, but they are not appreciating our condition. Okay. It's okay. One microplex coil is not detached. Now we need another one. Yes, problem with this. Okay. Bölünmedi. Yes, it's not detached. Bas. Yes, I hope now it's detached. Sure. As usually with the FD, it takes 5 minutes, but this stenosis is a contraindication for the stenting in this setting. Yeah. As the balloon is not in place, it's moved. That's why we'll continue with coiling. And, working. The previous one was 4 mm coil, and now it's again 4 mm.
How do you control the air vessel currently?
There is a balloon, Paul. There is a balloon, and now, okay, let's do control angio, but I hope everything is okay. The shape of the aneurysm is the same to the shape of DSA on the control screen. Just a second. Now I will do control angio. Бюджеттердің бәрін жондырасыңыз. Okay. You can see everything is okay. Марашка кім бар анда? Біреуін жондырасыңыз. I hope it's clear, the ICA is in place. It's not occluded. Just a second. It's a problem with the microplex all the time when you're taking
I don't
from
know if it's real or not, but the flow in the AC is much better than the MCA. It's like AC is more out of phase than the MCA. It might be a real thing, it might not be, I don't know.
Yes, there is a ACOM, and our guiding is creating some spasm. And also we did the suboptimal angioplasty for the carotid stenosis. That's why we see less the AC territory. Okay. It's quite a long procedure. That's why patient is moving all the time. Okay. Maybe this coil will be last, and then we can see about the замерзло. It's a cold inside the operating room, and the patient is complaining. Okay. Yes, it's a good sign. It will be the last coil. Кирюша, что здесь?
So for the juniors, the room temperature is really important. I think to keep the machine longevity, keep it cool, and keep it feeling like that or in the cold. But if you use the patient, hypothermia is not with them. And you can do a lot of things. One of them is that we use a bear hug, which actually blows hot air around the child, not to avoid hypothermia. Because hypothermia, this is not going to be that. The coagulation changes, the cardiovascular intestine. So temperature is the thing that keep the adults tolerate it better, that makes them uncomfortable.
Okay. Headway is out and eclipse is out. We'll do less zoom. And maybe now we can finish, but before the finish we will decide about intracranial stenosis of the ICA. Okay. Let's check. Yes, the ICA is in place. Okay. Kazakh thrombo test is passed, and now it's 25 minutes after placing the first stent. Just a second. I will take out my guiding from the stent. Okay. Okay, just a second. Okay. Okay. Now we can finish. Just a second. Okay. Let's do AP and lateral. And now you can see the ACA is filled from the common carotid, and it's a good sign that there is no problem. Okay. I think we need to stop at this stage of the operation, and if there is something needed, we can do in a second session.
So what did you decide for this
we will see, maybe we'll plan for the second session, but now the patient is completely non-controllable. We can do some complication, that's why. It's a slight stenosis, 2 millimeter for this territory with good ACOM. I think we can stop, but before I will check the neurological status. Как дела? Разговариваете? Подвигайте, пожалуйста, левой стопой. Левой стопой, другой стороной. Левой стопой. Yes, she's moving. Левую руку пошевелите, пожалуйста. Левую, другую руку. Вторую, вот эту руку. Пошевелите. Yes, she's moving. Now we will do expert CT, and then we can finish this case. Nader, Do we have time for the second case? It's a M1 segment stenosis, ICAT.
It depends how long you think you can have.
We need 30 minutes before the starting the streaming. 30 minutes, and then the procedure, I hope 15 minutes.
I think it will be because the session normally only half an hour maximum, so.
We will try to do quicker, but if it's not, then we will record and we will stream in Arabic. Okay? We will try to be on time. Okay. Okay, let's wait for expert CT.
Саш, трубку сейчас дерни.
Yeah.
Трубку здесь ты зал, не сшли. Вот смотри.
Yes, Nader. Just a second.
Really amazing toys and the steps.
Okay.
Бас, тис.
Just a second. Once again. I couldn't hear the question. So sorry.
It was just a compliment. I was touched by your voice and calm under pressure.
Thank you. Yes, when I will become chief of the hospital, then all patients will be under general anesthesia. It will take me maybe a couple of months. We'll see. Okay, the CT is coming. Yeah, it's clear. The MCA territory is clear. The brain is clear. Do you have any questions?
Questions?
Yes.
Any questions?
Yes.
Yes, you have questions.
Hello, this is Farouk. So, congratulations to you. So, do you have the plan the giving suggestions regarding platelet or checking for anticoagulants possibly because cardiac surgery, or what would be your plan for that?
We will recommend to delay the coronary bypass for 1 or couple of months. It's better because they will stop the dual antiplatelet and will shift for anticoagulation. Then it's a little bit risk of bleeding during the coronary bypass. In a 76 years old, I think they can wait on best medical treatment with the ticagrelor and aspirin for a couple of months. I think it's better. Farouk?
Given the excellent case, working on the stress that this is really exceptional. So thank you very much for this done, and I don't think we will have time for the second one.
Okay, we will be very fast. I hope we can do in 15 minutes. See you. Thank you, Nader.
Okay.
Тиз, екінші сынақ. Нет, Nader.